Thanks so much, Akgul, for the kind introduction, and I'd like to thank International Society of Urologic Pathology for this opportunity. Today, I'm going to discuss a somewhat marginal aspect of kidney tumors. I'm going to talk about high-grade kidney tumors, which are not very common, but occasionally we encounter them, and they are almost always diagnostically challenging. And I'm going to tell you why. During the talk, I'm going to tell you why I chose the word ugly 5 in this talk. I have no relevant financial conflict of interest related to this talk. So what I mean by high-grade kidney tumors might be a little bit confusing. I am not just talking about tumors with high nuclear grade. I'm also talking about tumor with high-grade infiltrative features. To give an example, the most common kidney cancer in adults, as you know, is clear cell renal cell carcinoma. And depending, regardless of the size and the location, most of the time what you see is a tumor with pushing borders type growth. And in this tumor on the left side, you can see the tumor is somewhat well differentiated. The gross features of clear cell is pretty reflective of the microscopy. And if you see these solid white areas in the tumor, it corresponds to sarcomatoid features. Despite the fact that we expect a sarcomatoid differentiation in this particular focus, it still preserves this smooth interface between uninvolved kidney parenchyma or uninvolved tissue and the tumor. Another tumor is chromophobe renal cell carcinoma, which is about 5% of kidney tumors, and you can have the same feature, very smooth interface between the tumor and the uninvolved kidney parenchyma. And microscopically, you will see the same thing. The tumor usually have tumors usually have a pushing growth, and you can have peritumoral fibrosis, hyalinization, and some atrophic changes in the nearby kidney parenchyma due to these mass effects, rather than infiltrative high-grade features. Most of the time, that's what you will expect. In the example of chromophobe renal cell carcinoma, you have the same thing. Again, smooth interface between the tumor and the renal parenchyma. Sometimes you can have unlucky distal tubules or sometimes even glomeruli encapsulated by the tumor, but it doesn't mean it is infiltrative. And even you have the renal sinus infiltration. In this case, this interface is almost always the same, smooth interface. Of course, occasionally you can have very aggressive tumors, such as this case. Sarcomatoid differentiation can happen in about 5% of the cases, and in this case, this infiltrative growth can be seen. There is no more smooth, well-defined tumor borders. It is just infiltration, and it shows itself in the microscopy. You can see on the right side we have relatively well-differentiated clear cell renal cell carcinoma morphology. On the left side, it is all sarcomatoid, and in this area we have these relatively high-grade clear cell renal cell carcinoma with glomerular infiltration. So when you are dealing with infiltrative high-grade kidney tumors, that the diagnostic approach should be somewhat different than our regular diagnostic approach to kidney tumors. I mentally classify these high-grade infiltrative tumors into 5. By the way, I'm not going to talk about primary renal sarcomas. They are very rare, and I am not very familiar with those tumors. So in this talk, we are not going to talk about the sarcomas of the kidney. These 5 ugly, annoying tumor classes will be associated with this probably nice children book, just to make this talk a little bit more pleasing. Otherwise, We are just going to talk about very ugly, aggressive tumors. First of all, we are going to talk about medullary-based renal carcinomas. It is not because of the fact that these tumors are the most commonly seen, but they are the prototypical infiltrative tumors in the kidney. And they are namely SMARCB1 deficient renal medullary carcinomas and collecting duct carcinomas. And then we are going to talk about urothelial carcinoma. We should remember that the kidney has some part of the urinary tract, and urothelial carcinoma can present with a high-grade infiltrative tumor involving the kidney. And then we are going to delve into a relatively large group of tumors under the category of molecular defined renal carcinomas. Most of the tumors we are going to mention is recognized, but there's one tumor we need to mention in infiltrative kidney tumors, which is currently at the emerging category. We should always remember that the common renal carcinomas can have high-grade features, as I showed you in one of the few first slides. And then after talking about the common renal carcinomas with high-grade features, we are going to talk about other tumors such as angiomyolipomas and metastasis, which can present with high-grade infiltrative morphology. The practical approach is not dissimilar to our approach to any tumor in any organ system. The clinical history should be complete when we evaluate any tumor, including high-grade infiltrative tumors in the kidney. Gender, age at the presentation, family history, and clinical conditions, particularly hemoglobinopathy, is one of the particular history that we need to check before our diagnostic workup. Gross and adequate sampling again should be present in any kidney tumor diagnostics. And one of the important things in this particular context is the epicenter of the tumor. Again, medullary-based renal carcinomas are the prototypical high-grade infiltrative tumors, and they are arising from the renal medulla, whereas most of the other kidney tumors are arising from the renal cortex. Macroscopic heterogeneity is important, and which should lead us to have additional sampling in the specimen. In tumors with high-grade infiltrative features, I believe additional sampling will be way more important than putting additional not so important second-tier immunohistochemical assays. Morphology will be the king, as it is the king in any area in surgical pathology. First of all, we need to check the relationship between the tumor, microscopically and macroscopically as well, but the relationship with the tumor and the renal pelvis. And we are going to check if there is any even focal areas resembling common renal carcinomas. Is there any focal area with clear cell cytology and nice vascular network, for instance? The particular importance in morphology would be tubular growth pattern, papillary formation, inflammatory infiltrate, and the type of the inflammatory infiltrate, and non-neoplastic changes in the kidney, for example, sickling of the red blood cells. And after that, we need to tailor our workup in terms of the findings we have. We shouldn't throw everything we have in any case, including these high-grade infiltrative tumors, but we should have a targeted approach to comprehensive workup. Let's start with the medullary-based kidney tumors. They are infiltrative by definition, and we have two types of tumors. One of them is SMARCB1 deficient renal medullary carcinoma and collecting duct carcinoma. It is rationally not very convenient to start with collecting duct carcinoma, because collecting duct carcinoma is actually a diagnosis of exclusion, but due to the fact that they are prototypically infiltrative tumors, we usually mention collecting duct carcinoma coupled with SMARCB1 deficient renal medullary carcinomas. When you look at the SMARCB1 deficient renal medullary carcinomas, it is part of the family of molecular defined renal carcinomas, which means you need to document the molecular alteration to diagnose it, which means you need to document the SMARCB1 loss in this case. And hemoglobinopathy is a very important critical information. Most of the cases, if not all, are associated with sickle cell trait. And we are going to briefly mention about what is happening in the SMARCB1 gene in this tumor. Whereas collecting duct carcinoma, again, is a diagnosis of exclusion. You need to exclude everything we are going to talk about today. And these tumors are essentially forming tubules, and they have extensive infiltration. They are virtually always having high-grade nuclei and desmoplasia. And these features, these morphologic features, are actually the diagnostic criteria for colorectal duct carcinoma. You need to have tubule formation, extensive infiltration, high-grade nuclei, and desmoplasia. Immunohistochemical assays will not help, but there are some clues in the chromosomal alterations that may lead us to the right direction. Let's start with an example. This is a 20-year-old unfortunate, unlucky male with a sickle cell trait. He had a 4.3 centimeter left renal mass, as you can see here, along with retroperitoneal lymph node and pancreatic metastasis. Before the treatment, the patient received neoadjuvant chemotherapy, carboplatin and paclitaxel, and I want you to give your attention to those regimens, because they are not very common regimens for common renal cell carcinomas. They are usually given to the patients with urothelial carcinomas. It is one of the things that the biology of the SMARCB1 deficient renal medullary carcinomas and possibly colorectal carcinomas are somewhat close to the urothelial carcinoma. That's why they decided to give this patient carboplatin-based chemotherapy. But unfortunately, the patient developed metastasis, disseminated metastasis, and deceased after died of disease after 9 months of diagnosis. And in the microscopy, you can see extremely infiltrative tumor with predominantly basophilic cytology, high-grade pleomorphism, and sheets of tumor cells. Sometimes you can see these pockets of tumor cells. Very ugly pleomorphic tumor cells with basophilic cytoplasm, and interestingly, these tumors have pulmononuclear leukocyte infiltration. It's a very common phenomenon for SMARCB1 deficient renal medullary carcinoma. And on the left side, you can see higher power image of the same pulmononuclear leukocyte infiltration. And as I told you, we need to check the non-neoplastic areas in the kidney, neoplastic or non-neoplastic, it doesn't matter. If you see if there's a patient with a suspicion of renal medullary carcinoma and known sickle cell disease, you can actually see sickling of the red blood cells. I'm not very good at it, but some senior pathologists can actually spot them easily. The molecular wise, what happens is a biallelic inactivation of SMARCB1 gene, and one of the genes are usually inactivated by a large deletion. And interestingly, the second allele is inactivated by, most of the time. Well, I should say half of the time, or the most common second allelic inactivation is translocation, which is kind of interesting to me. Immunohistochemistry, two immunohistochemical assay is very important. One of them is the diagnostic one. INI1 is actually the clone name for SMARCB1 protein, and diffuse loss of INI1 in the tumor cells in the background of retained expression in non-tumoral elements are vital to diagnosis, because sometimes you can have focal loss of INI1 in high-grade tumors. If you look at the TCGA data, there are about 500 plus clear cell renal cell carcinoma cases, and some of them you will see there will be secondary loss of SMARCB1 gene. They can lose focal INI1 expression. Whereas ACT4, although literature says that it is up to 50% of the cases, you can have a positive expression of ACT4. It is very unusual because ACT4 is something that we use in testicular germ cell tumor diagnosis if necessary. But in this case, ACT4 is positive in a subset of renal medullary carcinomas. And the reason why we call it SMARCB1 deficient renal medullary carcinoma is because sometimes you don't have young patients, mostly African descent with African ancestry with hemoglobinopathy. You have elderly patients without any hemoglobinopathy and SMARCB1 deficient renal medullary carcinoma. That's why the WHO, the latest WHO edition, puts this tumor into the molecular defined renal carcinoma category. The summary of the IHC includes loss of INI1, which is the most important thing, and again, diffuse loss, and the normal non-tumoral elements should retain INI1. PAX8 should be positive, as it is arising from the renal tubules. Keratin EMA should be positive. Interestingly, keratin 20 might be positive, as is with keratin 7. Some papers think that, or some papers suggest that p53 is almost always mutant in renal medullary carcinomas, but I don't see any senior GU or kidney pathologists using p53 for the diagnosis. Relevant negatives should be p63 and GETA3 because, again, in any high-grade infiltrative tumors, urothelial carcinoma should be in the differential and should be excluded. And retained stains include FH, 2SC, STHP, and Merlin. Outcome is unfortunately very dismal. Most of the patients present with distant metastasis already, as in the case I give the example, and most of the metastatic site is lymph nodes. It is relatively different than clear cell renal cell carcinoma, because the most common metastatic site is actually lung in the clear cell renal cell carcinoma, but lung is also frequently involved in this unfortunate aggressive disease. Treatments are not very helpful, and again, cytoreductive nephrectomy and platinum-based chemotherapy is the go-to treatment nowadays. There are some, I think, attempts to try immune checkpoint inhibitors, and there is also, I think, some buzz about erlotinib, which is a drug that is used in patients with lung cancer and EGFR mutation. Another case is, or another type of the tumor is collecting duct carcinoma. It is a particularly special tumor for me because until recently I should say I have high doubts about its very existence of this tumor, collecting duct carcinoma. Again, it's a diagnosis of exclusion. You have to exclude everything before diagnosing collecting duct carcinoma. But in spring 2025, when I was working here as a fresh faculty, we had a case of a renal mass in a 78-year-old male. He presented with fatigue, and imaging modalities showed there is a Wozniak 4 cystic mass. There were multiple cysts in this patient's kidney, but one of them was 6.2 centimeter. There were some papillary projections. I'm not going to show you these examples of these papillary projections because they are somewhat similar to what we have in the infiltrative component. And again, the imaging showed this enhanced infiltration to the renal parenchyma. And you can see the microscopic features of this parenchymal lesion. And later, after the diagnosis, they found multiple vertebral and iliac bone metastases. In here, you can see typical characteristic features of collecting duct carcinoma. There is diffuse tubular infiltration with desmoplasia, and the cytology is high grade. In higher power, sometimes they can have small nests, but these tubal predominance will be present in all cases. Again, tubal formation, desmoplasia, infiltration, and high-grade nuclear atypia are all diagnostic criteria for collecting duct carcinoma. If you do PAX8, you will have expression of PAX8 because they are arising from the ducts of Bellini, which is the most distal part of the kidney nephron. You can see some variations in the PAX8 stain, which was interesting to me because these relatively intense PAX8 stained structures were actually benign kidney tubules. As you can see here, the keratin 7 expression was negative in the tumor, but it was positive in the entrapped kidney tubules, and INI1 was retained because it is not a renal SMARCB1 deficient renal medullary carcinoma. I tried everything. I threw everything I got to diagnose this case without success, but due to the morphology plus a peculiar chromosomal abnormality, we decided to call it collecting duct carcinoma, which is multiple chromosomal alterations in some non-random chromosomes. such as 1, 4, 9, 18. These multiple chromosomal losses are different than what we see in chromophore renal cell carcinoma. And I was heavily dependent on Dr. Hirsch's experience in this case. And without her, I probably wouldn't diagnose cholangiocarcinoma carcinoma because, again, I had very high doubts about the pretty existence of this entity. But again, nature gave me an example of cholangiocarcinoma carcinoma. Retained stains include INI1, FH, SDHB. We should be careful about the Merlin. Merlin is a stain and its loss shows NF2 mutations, NF2 gene mutations, but NF2 pathway can be mutated in a subset of colorectal duct carcinomas, as well as renal cell carcinoma with renal cell carcinoma not otherwise specified. That's why Merlin loss does not necessarily mean an entity we are going to talk about later. Positive immunohistochemical assays include Pax8, keratins, EMA, but again, in colorectal duct carcinoma, you don't necessarily use immunohistochemical assays to diagnose the colorectal duct carcinoma, but to exclude others, because diagnosis of exclusion of other tumors are one of the diagnostic criteria for colorectal duct carcinoma. You have to exclude urothelial carcinomas and other aggressive tumors we are going to mention later. Some old papers underscore the importance of 34 beta E12, keratin 818. The senior authors that I'm trained with don't think so. The treatment, the studies about the treatment, like, on colorectal duct carcinoma is somewhat problematic, because are they really colorectal duct carcinoma? Because again, its diagnosis is pretty difficult to make. And there are studies showing that actually, older cases that were diagnosed diagnosed as colorectal duct carcinoma were actually something else. 25 in this study, led by Dr. Ohe, they basically reclassified 25% of colorectal duct carcinomas as fumarate deficient RCC. In a second, an older but more genomically comprehensive study, they did molecular analysis on 15 cases, and they found that two of the cases actually had homozygous deletion of a fumarate gene, which is, I think, diagnostic for fumarate deficient renal cell carcinoma. Again, when you look at the treatment data in these very marginal entities, we should be careful and we should be cautious about the cohort, how much contaminated these cohorts are with other entities. The second entity we should think of when we deal with the high-grade infiltrative tumors include urothelial carcinoma. So upper urinary tract is accounting for about 10% of urothelial carcinomas. They mostly happen in elderly patients, but they also can happen in younger patients. In gross examination, usually you are dealing with urothelial carcinoma because they are usually contained. The urothelial carcinoma usually is contained to the renal pelvis, but sometimes it can become somewhat expansile, and sometimes you cannot tell what you are dealing with. This is a nice case from my colleague and friend, Dr. Murat Oktay from Istanbul Memorial Hospital. And in this case, the kidney was entirely effaced by a very aggressive process. And on low power, you can see the pockets of tumor cells infiltrating to the renal sinus adipose tissue. The higher power image, I like you to look at them very carefully, because first of all, in the background, there's desmoplasia, and it is not super tubular. There are cribriforming type morphology in these tumors, but these tumors are pleomorphic, having high nuclear grade. As they are somewhat tubular. Again, there are some cribriforming, but colorectal duct carcinoma can have those tubules as well. In summary, they can look like colorectal duct carcinoma or renal medullary carcinoma. And you can see subtypes of urothelial carcinoma. It is not a very, very amazing example, but this is probably focally micropapillary subtype urothelial carcinoma. These are from the same case, by the way. Again, another interesting fact about the urothelial carcinoma is they tend to colonize the ducts first. And I believe some of these pockets of tumors are actually colonization of the renal ducts. So they can look like infiltrative by just colonizing the ducts. Immunohistochemistry is important, and I like 3 immunohistochemical assays to confirm urothelial carcinoma: P63, GATA3, and keratin 7. In this tumor, it is another case in an elderly patient with a very large infiltrative mass. They were not sure whether this case was from renal parenchyma or renal pelvis. P63 was diffusely positive and GATA3 was diffusely positive. But we should be careful about Paxate. So when you have a renal mass, you automatically order Paxate. But Paxate can be expressed in about 20% of upper urinary tract urothelial carcinomas. And there are some kidney tumors that can express GATA3. So some of the primary renal cell tumors can express GATA3, and about 1/5 of the urothelial carcinomas can express Paxate. We should be careful, especially diagnosing ugly tumors in renal biopsies. Another important aspect of the urothelial carcinoma is the association of the urothelial carcinoma with Lynch syndrome. So upper tract urothelial carcinomas are very common. I think some authors think that it is the 3rd most common malignancy in patients with Lynch syndrome. That's why some institutions, including us, it is not, I think, universally accepted, but most institutions, including us, screen these cases for mismatch repair deficiency. Here's an example of a renal pelvic mass. It is not as ugly as it looks, but I just want to give you an example of the urothelial carcinoma in the upper tract and the loss of mismatch repair protein. Let's start talking about molecularly defined renal carcinomas. It is somewhat a vague and confusing terminology. So we have a few, actually quite a few number of tumors that are, well, you need to show their molecular alteration to diagnose it. And this entity that I'm going to tell you first is actually an emerging entity, but they are most likely infiltrative in nature. So this is a case, another recent case of a 56-year-old female with 4.8 centimeter renal mass. Again, you can see this white lobulated mass, but it also has some infiltrative, look in the cut section. You can see the renal sinus is pretty involved. In microscopy, you see tubules and nests of tumor cells infiltrating the renal parenchyma, and you can see somewhat desmoplastic background and some papillary formations. You may or may not see some Mahmut's bodies in this entity, as in here. So there's a recently identified entity called biphasic hyalinizing Mahmut's renal cell carcinomas, and we know now that they are associated with NF2 mutations. And there's a very nice marker called Merlin. We have this marker clinically validated, and it is extremely helpful for us to, in the differential diagnosis of high-grade infiltrative tumors. And Merlin is expected to be lost in tumors with NF2 mutations, and it is very helpful in diagnosing biphasic hyalinizing Mahmut's RCC if the morphology is there. If not, it is not a specific tumor stain, because as I told you, NF2 mutations can happen in collecting duct carcinomas, and possibly I never seen any collecting duct carcinoma, because I've only seen one live case, and the Merlin was retained in our case, but technically speaking, potentially Merlin can be lost in collecting duct carcinomas. Merlin was first identified by our colleague, Dr. Katrina Collins, and again, it's a very helpful marker to document NF2 mutation. Other well, there's a typo here. It should be lost, but keratin, Paxate, keratins, and EMAs are expected to be positive in this case, and OCT4 should be negative. GATA3 and P63 should be negative. I'm kind of suspicious about like mainstream sentences about GATA3 because you never know. Sometimes GATA3 can be positive in some unexpected tumors. I will give you an example very soon. So I wouldn't rely on the GATA3 positivity when I call something urothelial carcinoma. Another case, probably relatively more recent than the previous case that I showed you, a renal mass biopsy in an elderly male, and again, it is it's a tumor with high grade atypia. There are somewhat papillary formation. They are mostly eosinophilic and even some like jet pink cells, but the nuclear atypia is present. And we ordered Paxate and many other stains. When we are dealing with tumors with high-grade infiltrative cytology, high-grade infiltrative features, we tend to order multiple immunohistochemical assays, and Paxate was diffusely positive, supporting the kidney primary. CA9 was patchy. One of the things I want to tell you is in any scenario, if you have a biopsy or a resection, it doesn't matter. One of the first things we need to make sure that we include or exclude clear cell renal cell carcinoma, because again, it is the most common kidney tumor with most options for the treatment. That's why one of the first things the urologists want to know is whether the tumor is clear cell renal cell carcinoma or not. And diffuse strong membranous CA9 expression is a very characteristic for clear cell renal cell carcinoma, even in the high-grade infiltrative setting. Most of the time, there are exceptions, but most of the time you will see diffuse strong and membranous CA9 expression. And in this tumor, Merlin was lost. Can I call it biphasic hyalinizing Samamoto's RCC? No, because A, it's a biopsy. B, there are some features resembling or suggesting that it might be a biphasic hyalinizing papillary renal cell carcinoma. But again, we should be mindful that other tumors can have NF2 mutation and therefore Merlin loss. Another molecular defined renal carcinoma is fumarate deficient renal cell carcinoma. I like to give this example. If you listen to my previous talks, this is one of the cases that really struck me. That's why I like giving this example. It's a patient with a huge kidney mass causing dyspnea. Actually, the presenting symptom was dyspnea, and the patient had a huge left renal cyst, and they drained it a little bit. The patient got better, but it didn't help. And for miraculous reasons, radiology thought that it was a benign tumor, and they first tried decortication. Believe me, it was interesting. Like technically, they tried partial nephrectomy in this case, and it was not so benign. There were some. It was mostly necrotic, but there were some papillary projections to the cyst, and the tumor was just ugly. There were very high pleomorphic, somewhat eosinophilic/basophilic cells in some areas, which prompted me to search for FH deficiency. These prominent nucleoli with perinuclear halo prompted me to search for FH. But interestingly, FH turned out to be retained in this case, and that can happen. That's why fumarate deficient RCC workup should be coupled with FH and 2SC. 2SC is a byproduct of FH mutation and should be cytoplasmically and nuclear positivity to call it positive. And overexpression of FH and overexpression of 2SC and loss of FH is expected in fumarate deficient renal cell carcinoma. But again, sometimes you can have retained FH expression. I had to send this case for molecular, and we found a particularly known, I forgot the actual point mutation, but we confirmed FH deficiency with molecular testing. Another case, In this case, it is mostly papillary and somewhat cribriforming maybe. And most of the time, FHRCC tends to have cribriforming slash papillary slash tubulocystic features, but it can have high-grade infiltrative features as well. And FH was lost as expected, with a nice positive control of the non-tumoral elements, and 2SC was positive in both cytoplasm and nuclei. I told you GATA3 can be very tricky, and we published a case report when I was a faculty at Albany Medical Center with Dr. Pacheco, who is now a surgical pathology fellow at Stanford University, gastrointestinal pathology fellow at Stanford University with Dr. Sangoi. And this case was actually diffusely positive with GATA3. The intensity was variable, but it was there. And it was also diffusely positive for CA9, and it's a known thing. So we should be kind of careful. Again, some exceptions are very annoying, but it happens, and we should be careful. We should be mindful of those very important exceptions. And GATA3 and CA9 were diffusely positive in this case, and it can happen in fumaratitis deficient cell carcinoma. We are not the only group that showed that fact. CA9 and GATA3 was shown to be positive in FHRCC in other studies, at least 2 or 3 other papers, including large cohorts. Another tumor is called TFEB amplified renal cell carcinoma. We have 2 types of TFEB alteration. One of them is a rearrangement, and the other one is amplification. TFEB rearranged renal cell carcinomas are indolent tumors. It is not a topic of today, but TFEB amplified RCCs are actually aggressive, and they are usually seen in elderly patients. They are kind of great masqueraders. They can look like very different things at the same time. These all 4 images are from the same case. This is a case that I got when I was a faculty at Albany Medical Center. And again, you can have clear-ish areas resembling clear cell renal cell carcinoma. You can have somewhat, I don't know, it looks like somewhat TFEB rearranged renal cell carcinoma or biphasic hyalinizing psammatosis RCC. We have these biphasic eosinophilic interesting areas. And again, this tumor can also look like FHRCC. And most of the time, it is not very consistent in TFEB amplified, but TFEB rearranged are more consistent with these findings. Melanate will be diffusely positive in TFEB amplified renal cell carcinomas. Again, this finding is most consistently present in TFEB rearranged renal cell carcinoma, but it can also happen in TFEB amplified RCC. Interestingly, keratin 20 is expressed in a subset of TFEB amplified renal cell carcinoma. Another interesting finding, well, amplification is should be present, and I think it is diagnostically mandatory to show the amplification. And still, we don't know how much amplification we should call as positive. I think 10 copies is now a somewhat standard approach, but some authors think that maybe we should reduce the number. Okay, another interesting thing is majority of these tumors are actually expressing PD-L1. This study showed that about 85%. I think this study on the top, yes. This study showed that about 85% of TFEB amplified renal cell carcinomas actually express PD-L1, which is not only helpful for diagnostics, but also directing the treatment. Another tumor that can look like aggressive high-grade infiltrative tumor is TFE3 rearranged renal cell carcinoma. We should consider TFE3 as another great masquerader. It can look like many things. This is a sample from a 33-year-old male with a previous resection in the kidney, and it was already diagnosed. And I just want to show you how they can become really aggressive. So this patient had recurrence at the pancreas distal spleen area, and when you look at this, it's a very highly aggressive looking tumor. And I mean, I knew from the hindsight that this was a TFE3. This was a patient with TFE3 rearranged renal cell carcinoma, and I ordered TFE3, which showed diffuse strong nuclear expression in tumor cells, and there are not very much, like, there are not a lot of non-tumoral elements here, but you can actually see that the tumoral elements were also diffuse negative, and it is a very important finding. If your TFE3 works, TFE3 is a very delicate stain. It is hard to make it work. Fortunately, our lab makes it work, but sometimes you can have, like, unreliable / inconclusive performance in this assay. But if you have this finding, it is actually diagnostic. You can diagnose TFE3 RCC in the context of morphology, of course. Some other tumors tend to have diffuse TFE3 expression, such as high-grade renal cell carcinomas. GPNMB is a stain for mTOR pathway mutations, and there is a close association between TFE3 and TFEB pathway and mTOR mutations. That's why most of the time GPNMB will be positive, diffusely positive in tumors with TFE3 rearrangement. And this tumor was actually known to have RBM10 TFE3 translocation. It is actually an intrachromosomal inversion type translocation. That's why FISH can be negative. And I just want to show you another example. It is not part of the infiltrative high-grade tumor topic, but the very first time I diagnosed a live tumor, a live TFE3 RCC, was actually RBM10. And look at how different the morphology is. So TFE3 RCC, even with the same fusion partner, can have very weird, different, morphology. In here, you can see more of a classical expected morphology for TFE3 rearranged cell carcinoma. Clear to eosinophilic cells, abundant cytoplasm, papillary features, and some momentous bodies. And I was able to diagnose this tumor on the biopsy, and this is the TFE3 immunohistochemical assay, diffuse strong expression. And the FISH came out negative in this case, as expected, and we confirmed RBM10 TFE3 translocation by sequencing. Another molecular-defined renal carcinoma, which is in the category of high-grade infiltrative tumor, is ALK rearranged renal cell carcinoma. It's a very interesting disease. I wish I will have it someday. I never got a live case yet. I'm just reading from other authors. So interestingly, ALK rearranged cell carcinomas can be associated with hemoglobinopathy, and when they are associated with the hemoglobinopathy, there's only one translocation, which is VCL ALK translocation. It's a very interesting thing, and similar to TFE3, ALK rearranged cell carcinoma can look like anything, but I think their high-grade look is more common than TFE3. I might be wrong, but I think they more often than not, ALK rearranged cell carcinomas can present with high-grade infiltrative disease. And we are now working on a case. I have 0 live cases again. I never seen that before, but we are now working with many of our colleagues, led by Dr. Anandi Lobo, on adult ALK rearranged renal cell carcinomas. Hopefully, we are going to finalize the publication and finish that. And this was from the latest ASCAP as a poster presentation. After the molecular-defined carcinomas, I would like to talk about a little bit about common tumors with high-grade infiltrative presentations. This case came to me last year. It was an adult male patient with kidney mass. He had a known kidney mass and multiple bone metastases. And first we got humerus metastasis. And look how ugly infiltrative high-grade looking tumor is. There was even some neutrophils, acute inflammatory infiltrates in this tumor, but SMARCB1 was retained. PAX8 was positive, fortunately. CA9 was negative, and racemase was diffusely positive. So they wanted to know what it was, and we failed to characterize it by just regular morphology and immunohistochemical assays. And they actually diagnosed clear cell renal cell carcinoma by just NGS. They just showed the VHL mutation to start the treatment to the patient. After the treatment, finally they resected the nephrectomy, and out of 52 blocks, we were able to find relatively well-defined clear cell renal cell carcinoma areas in the nephrectomy. So As I told you in the beginning of my talk, sampling, adequate sampling, liberal sampling is sometimes more important than immunohistochemical assays. Other tumors, I'm just going to briefly mention. One of them is a rare manifestation of relatively common tumor. It's a mesenchymal tumor. It is called epithelioid angiomyolipomas. Classical angiomyolipomas are benign tumors. They are mesenchymal. It is relatively easy to diagnose, but sometimes they can look like crazy, atypical high-grade infiltrative tumors. The diagnostic criteria for epithelioid AML is, I think, somewhat arbitrary, but what I would like to see is high-grade atypia, multinucleated tumor cells, atypical mitotic activity. In this case, was from a 35-year-old female with large right renal mass, and I got both the resection and the biopsy. And in the biopsy, Paxate was negative, SMA was diffusely positive, and HMB45 was positive. So it was an epithelioid angiomyolipoma. If you have cathepsin K, it is relatively more helpful than HMB45. And they're also positive for GPNMB because epithelioid angiomyolipomas have mTOR mutations. A portion of the epithelioid angiomyolipomas can also have TFE3 rearrangements. So you can TFE3 can be positive with in a subset of epithelioid angiomyolipomas. I forgot to mention some of the ALK cysts can also have TFE3 expression, diffuse TFE3 expression. We should be careful. Metastatic disease, these are my last slides, and hopefully within several minutes I'm going to be able to finish. So metastatic disease also should come to mind when we are dealing with high-grade infiltrative tumors. The most common metastasis is considered to be from the lung, followed by breast and gyne. And in this study, it is relatively old, but it's a very enlightening study in terms of metastatic disease to the kidney. There are some interesting facts. For example, the metastasis of other organ to kidney is relatively long. Like there's usually a time frame between primary tumor and the metastasis. In this study, it was 3.1 years. And these metastases can be solitary. You're expecting these metastases to be multiple, bilateral, but it can be solitary, and it can be cortical, and it can be medullary. So medullary manifestation of a solitary metastasis can fool us as if it's a medullary-based primary kidney tumor. And speaking of metastasis, I am sorry for shameless self-promotion, but we recently published a series of 10 metastatic adenoid cystic carcinoma to the kidney. I just wanted to show you some weird tumors can go to the kidney, and we should broaden our differential when we have unusual tumors. This is my last slide. It is an attempt to simplify as an algorithm to the diagnostic approach of high-grade kidney tumors with infiltrative features. Again, initial evaluation is important, clinical history and adequate sampling. If the patient is of a younger age, we should think about hemoglobinopathy. And if there's hemoglobinopathy, we should we should tailor our diagnostic workup for somacriptan deficient renal cell carcinoma and renal medullary carcinoma and ALK rearranged renal cell carcinoma. And INI1, ACTOR, and ALK are the main important immunohistochemical assays, excuse me, to perform. If no, we should, if the patient is old or if there's no hemoglobinopathy, we should check if there's an Paxate expression. If there's an Paxate expression, we might consider this tumor as renal primary. If there's no Paxate expression, urothelial carcinoma should come to mind. But again, we should remember that 1/5 of the cases can express Paxate. And for urothelial carcinoma, again, I like P63, GATA3, and keratin 7 expression. It can be metastasis. Again, the most common metastasis is lung. It can be epithelioid AML, and I didn't talk about these entities, but primary sarcomas should also be considered, or sarcomas arising from the perirenal area, retroperitoneal area should be considered when you have really crazy, interesting tumors. If the Paxate is positive, again, as we mentioned, molecular defined renal carcinoma should be in the differential, but again, common RCC, especially clear cells, should be excluded because most of the time, almost always, high-grade infiltrative tumors will be very aggressive tumors, and most of the time, often it will present with metastatic disease. So the urologist, the medical oncologist will die to learn whether this tumor is clear cell or not, because again, clear cell has a lot of many options in terms of treatment when compared to non-clear cell. We have to rule out clear cell renal cell carcinoma, and CA9 is a critical immunohistochemical assay for that. Molecular defined renal cell carcinoma, again, it's a broad group of diseases, and we should just order as much immunohistochemistry as we can, but it should be tailored to what we are looking for. For example, if I mean, we should order our immunohistochemical assays in terms of tiers. I mean, in the first tier, you don't need to order like Merlin all the time. If your tumor looks like, I don't know, TP3 rearranged renal cell carcinoma, you may have to work your way around, like tailor your immunohistochemical assay to diagnose TP3 rearranged renal cell carcinoma. If you fail with everything, we are left with colorectal carcinoma and excuse me, renal cell carcinoma with renal cell carcinoma not otherwise specified. Unfortunately, with all of our attempts, we might fail to just characterize the kidney tumor, and all we have might just be renal cell carcinoma not otherwise specified. I'm going to stop here talking. I'd like to thank Dr. Michelle Hirsch as a great mentor and collaborator, as well as Dr. Williamson, Dr. Sangui, great mentors and collaborators, and Dr. Murat Oktay for his generous gifts of those images for my talk. If you have any questions, any feedback, please email me. And you can use this QR code to access to my Harvard Catalyst website. I have my contact info over there, and please shoot me an email if you have any feedback and question. Thank you so much for listening to me.
Thank you, Dr. Akgul. We do have some questions in the Q&A. I'm happy to read them, or if you would prefer.
Okay, let me stop sharing, and then I'm just
sure.
going.
It's up to you. Sometimes
Sure,
it's easier.
But Dr. Alperen Yildirim says, thank you, Dr. Akgul, for the presentation. Can you share your initial diagnostic workup when you see an ugly tumor? Well, again, depending on the age, I think this algorithm kind of speaks for itself. I'm kind of mentally following this algorithm. And again, clinical history is important. Hemoglobinopathy will make me thinking of SMARCB1 deficient renal medullary carcinoma. Usually, high-grade infiltrative tumor immunohistochemical workup is kind of comprehensive, rather, when compared to the main, more common kidney tumors. Again, this algorithm is something that I follow. An anonymous attendee asked, when do you include TFE3 in your immunopanel? It's a nice question. When I have a suspicion about the TFE3 RCC, it is one of the first immunohistochemical assays that I think. But when I see a kidney tumor with high-grade infiltrative features like this one, I like including TFE3 and also FH, 2SC, STHB, and other possible immunohistochemical assays. Dr. Mohammed Ahmed, I made a diagnosis recently of a TFE3 rearranged renal cell carcinoma. Actually, FISH was negative, but RNA sequencing identified a known partner. Yes, it was interesting. Yes, this is a known partner. NO is one of the known partners associated with intrachromosomal alterations. There are some of them. It's not just RBM10. We have RBMX, NO, GRIPUP1, GRIPUP-X, I think, and some probably others. There are more than 20 fusion partners of TFE3 in this rearranged renal cell carcinomas.
Yeah, I've always wondered, I'm sure if you could collect enough data and cases, unlike fusions in soft tissue tumors where it's one partner pair, it has a very similar look, right? So you get this sort of like consistency, whereas the TFE family with all of their different fusion partners, that's why it's so hard to say this is what it looks like. We have kind of a classic example, but there's a real broad spectrum, I think, of morphology, and it's due partly to all those different fusion patterns.
That's correct. Dr. Argani has a very nice paper pointing this morphologic heterogeneity and possible relationship between fusion partners, even morphology and immunophenotype. It was from 2016, and it is published in American Journal of Surgical Pathology. And in this paper, you can actually say let's say, clear cell tubulopapillator-like morphology can be associated with SFPQ fusion partner or NO fusion partner, whereas papillary RCC TFE3, which is one of the first identified translocation in TFE3 rearranged cell carcinoma in pediatric patients, you can actually have papillary formations. And in PRCC, TFE3 rearranged cell carcinomas, you can actually have more cathepsin K expression and melanistic marker expression. So somewhat the morphologic heterogeneity in TFE3 rearranged cell carcinoma is somewhat associated with fusion partners. But again, in this two example that I showed you, they were RBM10 TFE3 and they were completely different. So yeah.
We've got one more question that's just been added to the Q&A.
Sure. Do you perform MMR IC on urothelial carcinoma involving ureter? Yes. It is considered upper urinary tract, and we screen those tumors for MMR deficiency.
Yeah, we also are doing all upper tract high grades are getting MMR IHC in our group.
Yeah, sorry, high grade as well. Yeah. I don't think we are doing in low grades. Yep.
All right, we have a couple more minutes. Anybody else have any questions? Going once, going twice. All right. Well, thank you very much, everybody, for joining, and Dr. Akgul for your time. We will continue on next month with ISUP Presents. Please keep your eyes peeled. For those of you who aren't aware, the ISUP website has been revamped and relocated. Let me make sure I have the right address. But please check, if you were a member, please check and look in your spam folder, because as the new emails have gone out, we're finding that a lot of them have ended up in people's spam folders. So we want to make sure you're getting all the information, not just about ISUP Presents, but Case of the Month and upcoming ISUP events. So I put the website in the chat. And yes, thank you all for attending, and we'll see you next month.
Thank you.
Bye.